Greetings. So let's talk about potassium and potassium disorders. So just a recap, if you've seen the videos before, potassium is in extracellular fluid and also in intracellular fluid. Where is it more? Intracellular space, right? It's in lesser amount outside the cell, and that's 3.5 to 5 milliequivalents per liter. So it's very narrow, and so it's much less, and the therapeutic range is very narrow outside the cell. What does it do and where does this bother us is potassium's symbol, chemical symbol is K, and EKG has K in the middle. So this helps you remember K disorders or potassium disorders give rise to cardiac arrhythmias. And these are lethal, okay, because they directly affect the cardiac output, okay? So let's take a look at that first. Now, you may know a little bit about EKG or you may not. We're going to cover it in the cardiac section. I'll give you a little quick primer here. So this is a normal EKG. You have, you have an isoelectric line. We put an electrode on the patient, and then we have a little deflection in the positive side or above the isoelectric line, and that's called P. Okay, and then it comes back, and then very shortly after that you have a little negative deflection, that's Q, and then it goes up, and then it comes down again, and then it gets back to the normal line. So this positive reflection after Q is R, and then this actually goes below the isoelectric line, and this becomes S. So this is P. This whole complex is QRS, and then you get back to the isoelectric line, and then you get a T. Okay, and that's a normal EKG. Like I said, we'll look at it in more detail when we look at the cardiac lectures. But what potassium does is it changes the electrical activity. So I'll share with you how. Uh, I want you to know it. Here's the reason. In exams, you can be asked with some key terms that I'm going to cover here. And they might want to tease out whether you know what the EKG changes are with regards to potassium. As the tests are getting more intense and next generation, uh, I I foresee that uh, a clinical case may be given and an EKG strip may be given. So not only do we need to know what the changes are and learn the changes, we need to recognize it on EKG. Okay? These are some very basic changes. So again, I am going to share with you what those changes look like on EKG. I want you to know it, and I want you to recognize it when you see it on EKG, especially when you are through the EKG lecture. So the biggest, most important area to look at for potassium disorders and changes with EKG is T. If this T peaks, you got too much potassium because it's peaking. If this T wave flattens out, it's going down, you got less potassium. That's it. That's actually the biggest change. There's a couple of ancillary changes around it. Let's take a look at it. So whenever it's hyperk, it's too much. You see, this was the T. This was the T. See how it peaked? Okay. What else? There's three other findings you get to see. So you see the QRS is pretty tight here, right? Very tight. It's usually there's a number associated with a normal QRS. Okay. If you see here, the QRS has become wider, or the QRS has prolonged. That's the second change with hyper K. The third change, you see the P flattens out and goes away from the QRS complex. So you see here the P is flattening out and going away from the QRS. So these are the three changes. The biggest, most high yield change you're going to see is peak T waves. Okay. Now let's go to low potassium. Guess what? Again, it's the T wave. So remember that T wave flattens out. What else? There's another wave that takes its place that comes after the T wave. That's a U wave. That's another positive deflection after T wave and before the next P wave. So that's the U wave you're going to see. Okay. Again, one may see ST depression, but again, there's other cardiac abnormalities associated with ST depression. So if I have to remember something for potassium and EKG changes, it's the T wave. If you want to be amazing, awesome student and awesome nurse, awesome provider, remember hypokalemia, you see a U wave. Hyperkalemia, you may see prolonged QRS and P flattening and getting away from QRS. Okay. Essentially, if both of these, hypo and hyper, are life-threatening, especially hyper, if you continue to let the potassium levels be high, this is what you're going to see, which is VTach, which will then progress to VFib. Ventricular tachycardia, which would progress to ventricular fibrillation. Essentially, the heart's going to quiver and it's not going to give you any cardiac output. And if it's VTach, it's going to give you very low cardiac output. Both of these are what? Life-ending rhythms. Okay? You don't want to go there. How serious is this? So for executions of prisoners who are convicted, you use potassium to stop their heart. You give them an IV bolus of potassium along with some other drugs. That is how serious this drug is. That is how serious these abnormalities are. That is why test makers want to make sure that someone is safe when they get on practicing and seeing real patients and are able to recognize and rescue patients from these conditions. Okay? That's why it's very high yield. Okay. So let's talk about potassium in the blood and how those levels change. So this is normal potassium. So you get your potassium from taking it in. I take a banana, I drink some coconut water, and guess what? I'm consuming more potassium, right? Okay. The other part of it is excreting it. So your potassium is excreted by kidneys. Okay. And the hormonal control, aldosterone is one of the key players. So remember, aldosterone, if it senses potassium, it can actually act by itself. And what it does is it says, you know what, I'm going to reabsorb sodium and water, and I'm going to pee out potassium. Okay, that's what it does. Okay. The third part is redistribution. So remember, potassium is more in the intracellular space or the extracellular space. It's more in the inside the cell or in the intracellular space. But there are conditions that get the potassium to go from intracellular space to extracellular space and vice versa. So let's take a look at what gets potassium to do that. Okay, so whenever you have less calcium, right, in your blood, what are things that can go wrong? Well, you may not be eating or drinking a lot of things with potassium, so low intake, right? Good, easy. What else? One may be excreting a lot of potassium. Okay. Now, there's a couple of ways where one can excrete a lot of potassium. Kidneys are very sensitive to potassium and they keep this show running very tightly. But if there's an abnormality, especially in conditions where the aldosterone goes out of whack, okay, goes bad, okay, what happens? You know what? The kidneys are not able to properly regulate potassium. So again, if aldosterone excretes potassium, you have too much aldosterone, you're going to pee out a lot of potassium. So these are renal causes. Okay. There could be non-renal causes. For example, if somebody has vomiting or diarrhea, that's GI, gastrointestinal loss. Okay, so that's non-renal. Okay. What else? Well, you can have the potassium that's redistributed from outside the cell to inside the cell. So that's going to decrease the concentration of potassium outside the cell. So what are things that can do that? So the way I think about this and the way I learn it, and this is the way that may help you, is whenever you're getting ready to fight, all those conditions cause your potassium to redistribute from outside the cell to inside the cell where it's more because it's getting ready for a fight. It needs to go where it belongs, inside the cell. So what are these things? So whenever I'm creating more cells, I am moving potassium from outside the cell to inside the created cells. These are more cells I need to fight. Okay? Juice out. What else? Well, if I need to fight, I need the sugar to go inside my cell. So I need the insulin to take it inside my cell. So if I have more insulin, hey, potassium's going to go from outside to inside. The levels are going to go down. If I stimulate my lungs through beta 2 sympathetic receptors, which cause bronchodilation, that additionally actually gets the potassium to go from outside the cell to inside the cell. I need that when I'm fighting. I need more oxygen. I need to blow off more CO2. Okay. And then I also want to make sure I become more alkaline before I fight, because when I fight, I'm going to use a lot of sugar, and sugar is going to give me CO2, which is going to make me more acidotic because CO2 plus H2O gives me carbonic acid, H2CO3. So CO2 gives me more acid, right, when I'm fighting. So as I'm getting ready for fight, I need to make sure my pH is higher. So that means I'm more alkalotic. Okay. And again, we're going to talk more about acid bases. So if you're not sure about this concept, just learn it for now and make sure you put the acid base video on your list to watch after this. Okay. So again, high pH. So these things, beta 2 stimulation, insulin, pH, creating cells, all of this takes the potassium that's outside the cell to inside the cell. I want you to know some of this information because in a moment we're going to use this information to treat potassium and potassium abnormalities. Now, how can you increase the potassium? Okay, how can I increase the potassium? Okay, so again, there's different ways one can do it. I can increase the intake. But here's the deal. Unless I have some issues with my kidneys, if I take more, my kidneys are going to tightly regulate it and pee it out. So again, if my kidney function is not good, or I got too little aldosterone, and somehow I'm in a low aldosterone state. Because of that, the potassium is not going to be excreted, and I'm going to build up a lot of potassium. Okay, so intake and kidneys, the excretion, which is really, really important in this case. Now, what else? I can redistribute it from inside the cell to outside the cell. And the way I remember it is, remember we got ready for the fight, that's when potassium went down, right? Potassium goes up after the fight. What happens after the fight? Well, there's some cell damage. So cell lysis, the potassium inside the cell gets outside. I'm more acidotic. So if my pH is low, that potassium goes from inside the blood to outside the blood. If I have states where there's low insulin, that potassium goes from inside the cell to outside the cell. Lastly, if that sympathetic beta 2 response is not there and I'm inhibiting that response, that potassium will go from inside the cell to outside the cell. So I don't need my lungs to blow off a lot of CO2 anymore because I'm done with my fighting. I'm resting and relaxing. Okay? So that's what the general approach is to understanding what's causing the potassium to go up or down and different mechanisms. Okay, so again, we talked about the narrow range and what does potassium do? Causes issues with EKG or electrical activity of the heart. So let's talk about some principles of management of potassium and its abnormalities. First thing to check, potassium plasma levels. How high or how low? Okay, a potassium level of 9 obviously is very high and much, much more troublesome than, say, something like 5.2. Second, I am going to confirm um, whether the patient does have the potassium abnormality that I am seeing on the levels in the lab. How real is it and how stable is it? If I see the EKG changes, I know it's for real and I know it's unstable. I got to do something about it because that's the potassium outside the cell is irritating the myocardial cells. And it's an accident which is going to happen pretty soon unless I do something about it. Okay? Rechecking potassium to rule out false elevation and decrease in potassium plasma levels. So again, we get the lab, and let's say we just treat it without confirming it. Guess what? That narrow window, a lab error, is going to lead to patient death. So again, rechecking potassium is very, very important. And we'll actually put all of these principles into a decision tree. And once you know the decision tree and you understand it, uh, clinically or in real life or on a test, you will be able to slay all the questions and take care of clinical situations. Okay? Potassium replacement. If you have to replace potassium, okay, there's a few principles, and let's go through them together. So remember when we were measuring particles, right? Remember that time? We were measuring particles. We were measuring particles. And then what did we do? We said, okay, we can measure a solute in a solvent. We can say, okay, I have this many milligrams in these many mLs or liters. So that was concentration. I said, okay, another way to measure is particles in volume, right? And that will lead to concept of osmolarity, osmolality, and tonicity. Remember that? Okay. Now there's a third way to measure things. And that's especially true for when I am talking about cations. Remember positive charge cats? Cations. And what I say is I have a proton, which is my hydrogen ion with the electron removed. Now, 1 milligram of hydrogen, right, will give me the Avogadro number 6.023 into 10 raised to the power 23 particles, right, of hydrogen. Now, if sodium, right, sodium has one charge there too. If its molecular weight is 23 milligrams, we're going to have 6.023 into 10 raised to the power 23 particles of sodium. And since sodium gives us, again, one positive charge like the hydrogen ion does, both are same in terms of their electrical activity. And what we say is that 1 milligram of hydrogen gives me 1 milliequivalent of electrical activity. So sodium 23 milligrams gives me the same electrical activity as 1 milligram of hydrogen ion, which is the same as 1 milliequivalent. You with me on this? So essentially, it's a way where you try to see how much amount of the cation, how many, how much mass of the cation has the same electrical activity as a hydrogen ion? Okay. So let's say if it's potassium, potassium also gives me one charge, one positive charge. One particle gives me one positive charge like the hydrogen ion does. Its molecular mass is 39 milligrams. So 39 milligrams of potassium is 1 milliequivalent of hydrogen ion, or just we call it 1 milliequivalent, which is the same as 23 milligrams of potassium cation. Okay. Now let's apply this concept. Okay. So let's say I want to give somebody 40 milliequivalents of potassium. Okay. How much potassium, how many milligrams of potassium do I need to give them? Well, if 1 milliequivalent gives us, if we can derive from 39 milligrams of potassium, 40 milliequivalents we can derive from 39 times 40 milligrams of potassium. Easy, right? Perfect. Okay. The concept is, now that you know this, if you give somebody 10 milliequivalents of potassium, we increase their plasma concentration of potassium by 0.1. So let's say somebody has a potassium level of 3.3 milliequivalents per liter, and my target is they get to 4.0 milliequivalents per liter, right? What's the difference between where they're at and their target? 0.7 milliequivalents per liter. Is that correct or not, right? Okay, so let's do some ratio and proportion. So to increase the potassium level by 0.1 milliequivalent per liter, I need to give 10 milliequivalents of potassium. If I were to increase, if I'm targeting an increase of plasma potassium by zero point 0.7, I need to give 7 times 10, that is 70 milliequivalents of potassium. So you see, that gives you a rough ballpark idea when you're thinking about dosing a patient. Okay, perfect. Now, if the patient has real hypokalemia and it's stable, give things by mouth, and they can take it by mouth, give it by mouth. That's the best way. Remember sodium? That's actually true for all nutrition and electrolytes. If they can take it by mouth and they're stable and life is good, GI is the best way. If they are unstable or cannot take by mouth, then only use the IV route. When you're giving by mouth, potassium chloride is most commonly used. There's a couple of other preparations, and if you want to study more, I think that would be a good opportunity to learn more on your own time. Okay, but potassium chloride is most commonly used. If you're giving by IV or intravenous, what we do is we have a solution and we add a certain amount of potassium chloride or one of the salts to give you some milliequivalents of potassium in that solution, and that potassium is run through somebody's intravenous line. It is not bolused. Potassium is never bolused, because if you do it, you will execute the patient like we execute the prisoners. Okay? We kill the patient. They go into VFib and or VTAC and they die. So we actually give them potassium in the solution at a set rate. And that set rate has to be based on two numbers. And I want you to remember these numbers. Again, this is high yield. If you're giving it through a peripheral IV, there's a high likelihood of pain and phlebitis. So it is a lower flow rate. You can't give it faster than 10 milliequivalents per hour. if you're giving it through a central line, you can't do it for anything over 20 milliequivalents per hour because of the cardiac issues. Okay? Pearl, if you see hypokalemia, check their magnesium. If magnesium is also low, replace it before or as you are fixing their potassium. Okay? These are some pearls. Okay. So let's kind of continue our journey and let's do a little bit of math. Okay? That'll give you an idea of how this solution we are talking about. Remember this solution that's given IV? What usually happens is in your hospitals, the pharmacist is going to prepare the solution or it will come pre-made. Where you're going to, let's say, have a solution like normal saline or D5.5 normal saline. And there's going to be 20 milliequivalents of potassium or 40 milliequivalents of potassium. So the question is, I have, let's say, 1 liter solution of sodium chloride, 0.9%, and I have 40 milliequivalents of potassium chloride in there. So how much of sodium chloride is in there? How many grams? And how much potassium chloride grams are in there? Let's do a little calculation. So potassium chloride, molecular weight is 75, right? So 1 milliequivalent of potassium you get from 75 milligrams of KCl or potassium chloride. So if you want to get 40 milliequivalents, you got to multiply that amount multiply the 75 by 40. That many milligrams will give you 40 milliequivalents of potassium. That's potassium chloride. So that's 3,000 milligrams or 3 grams of potassium chloride is actually added to that 1 liter solution to give you 40 milliequivalents of potassium. Well, what if the solution was also 0.9% sodium chloride? Well, what does that mean? That means 0.9 grams of sodium chloride was mixed in 100 ml. Now the solution is 1000 ml because it's a liter. So you're going to have 9 grams of sodium chloride. So when you see a 0.9% sodium chloride with 40 milliequivalents of potassium in there, which is, developed by using potassium chloride, you know that there's now 9 grams of sodium chloride in there, and it's also got 3 grams of potassium chloride. That's what the solution is. Okay? Perfect. So now you have an idea of a little bit of mathematics around this and how we come up with these solutions, right? So what's the goal when the potassium goes out of whack or goes bad? The first goal is to prevent the complications of hyperkalemia. And what's number one? Cardiac arrhythmias. We got to stop that. And then we got to diagnose and treat the underlying cause. Okay? And that's true for all electrolytes and fluids. They are just what we call a symptom or sign. So we've got to make sure that we manage them if they're life-threatening. And then once that's fixed, as we're fixing that, we diagnose and treat the underlying cause. Okay? So before we go to the decision tree of how we are going to approach a patient with hypokalemia, let's do a little bit of thinking because I think it's going to help once we start to put the picture together, and that's the final piece that we are going to take a peek at. Okay, so let's say a patient has very high potassium in their blood. Okay, so is it because the patient is eating too much? Could be. However, we know for a fact that the kidneys have to be in trouble for us to have this potassium be high, right? So let's say is the patient having acute or chronic renal failure? Let's say no. Okay. we can then check and see if the aldosterone is doing good. Remember, that's that other hormone. So again, aldosterone does what? It pees out. When aldosterone is there, it pees out potassium and it holds on to sodium and water. Okay, now when the body sees too much potassium, it activates aldosterone and makes it pee out all the urine. So if I do a urine sodium and aldosterone is working great in a hyperkalemic patient, what are you going to see? Urine potassium is going to be high. With me on this? If potassium is high, aldosterone, if it's working well, again, should be peeing out that extra potassium, which would increase the potassium in the urine, which would tell me aldosterone is working great. So if the kidneys are not in failure and you have high urine sodium in a hyperkalemic patient, then that tells you the reason for the increased potassium is not kidneys because they're not failing and the aldosterone is working great. It's non-renal causes. Okay. However, if the urine potassium is low, that means aldosterone's not working, man. Or kidneys are in failure. That tells me kidneys are the culprit. That's renal cause. Easy, right? See, if you know some basics, you can think through what's going on. You don't have to remember. That's essentially what it is. Urine potassium is high, causes non-renal. If it's low, it's renal. Now it's your turn. What if the patient has low potassium? Okay. Again, their intake may be low. Let's say their intake is fine. Okay. I go to my kidneys and I see, okay, are my kidneys conserving potassium? Why? Because the potassium is low. My kidneys and my body needs to conserve potassium. Okay. So my aldosterone would be there, right? What does the aldosterone do? It would pee out the potassium. But wait, my potassium is low. So the appropriate response is my urine potassium should be very, very low. Why? Because I don't want to pee out my potassium. I want to hold on to that potassium. So if my urine potassium is low in a hypokalemic patient, guess what? My kidneys are working exactly like they should. And so the hypokalemia is non-renal in etiology or an underlying cause. However, if my urine potassium is high, man, them kidneys are not holding on to my potassium, and the cause for the hypokalemia is renal. Okay, got it? See, that's how simple all of this is. Can't can't learn too much of this. If you know some basic principles and you're ready to apply it, you can pretty much figure out where things are going. Okay? Now, let's bring it all together in a patient where there's a report of hyperkalemia. Okay? You get called by the lab and there's a critical lab value, okay? And you call the provider. What do you anticipate is going on through the provider and how would we approach the patient? Okay, so step one, we're going to order an EKG. It's going to be a 12 lead EKG. If it shows T waves that are peaked, QRS that's broad, remember we went through it a second ago, P that's flattening and going away from QRS, I am seeing electrical activity consistent with hyperkalemia. It's for real. and it's unstable. So EKG is showing hyperkalemia. It's real unstable hyperkalemia. I have to do something about it right now. It is an emergent problem. So, priority, protect the heart, then diagnose and treat. So how do I protect the heart? I give them calcium chloride. Well, sir, this is a problem of potassium. Why are you giving them calcium chloride? Calcium chloride stabilizes the heart cells. And the heart cells that are getting irritated by this extra potassium, they're going to get less irritated and they're going to stabilize for a bit. That means I'm not going to throw life-threatening rhythms. Now, this given immediately works for minutes and gives you some time. Next, I have to redistribute this sodium inside the cell. This potassium inside the cell. So potassium that's outside in the blood and ECF is irritating the heart. I got to get this temporarily moved into the intracellular space. How do I get potassium to go from outside the cell to inside the cell? When I am getting ready for a fight, okay? And I get ready for a fight if I have a lot of insulin, if my pH is high, and if I invoke my beta 2 receptors, which bronchodilate me. Remember? Aha, if you can remember this, guess what we do to the patient? We give them insulin. Choice 1. Choice 2, we can give them sodium bicarbonate. Choice 3, we can give them drugs which bronchodilate them, which stimulate the beta 2 receptor like albuterol. Okay. We give somebody insulin. It's great. It's preferred. It's fast. We give them insulin IV. What does that do to their blood sugar? It's going to decrease their blood sugar. It's going to tank it. That's why we give it D50 or dextrose 50 solution with the insulin. So that way we don't put the patient in hypoglycemia. If we don't give the dextrose 50 solution, we are going to stop the potassium from wreaking havoc on their cardiac cells. But we are going to trade it for the other emergency, which is hypoglycemia. Okay? You with me on this? So again, insulin plus D50. So a lot of times when you're doing this to the patient, if you don't understand this principle, you're going to be thinking the providers have lost their mind. They're giving the patient insulin and D50. Doesn't make any sense. Why am I giving somebody sugar and medicine to decrease their sugar? Well, hey, you're not giving it to manage their sugar. You're giving it to manage their potassium and not put them in hypoglycemia. Sodium bicarbonate will increase the pH, make them less acidotic, move that potassium in the cell, and so would the albuterol. And this will do it for a few hours. Okay? This would do it for the few hours. What if the patient is very symptomatic, very unstable, and we don't have time for all of this? What can we do? Like with oral fluid and electrolyte imbalances, we can put a Quinton catheter or a dialysis catheter in the patient and dialyze the patient. Okay. If the patient is already on dialysis and they are getting hyperkalemia because they've not been dialyzed, let's dialyze them. That'll fix the problem. Okay. But that's priority one, is this is how I protect the heart. I stabilize the cardiac cells for minutes, which buys me minutes, and then I redistribute potassium inside the cell, which stabilizes it for hours. If the patient is very unstable and or has a history of dialysis with a catheter in there, dialyze them. Okay? You with me on this? Now this is what you are. This is not the end. What we have to do is get rid of this extra total body potassium. Because after the R's are done, the potassium is going to sneak back in and we're going to be in the same situation. How do we fix the total body potassium and excrete it? There's two ways. Way one, most commonly used, Kxalate, the drug, and we'll talk about it. The other name is sodium polystyrene. Number two, we give them a diuretic by the name of Lasix. Okay? Makes them pee out the potassium. What's the problem? Remember which organ is the best excreter of potassium? Kidneys, right? And we have to have kidneys that are not acting right. That's one of the big reasons for hyperkalemia, too much potassium, right? Because it's not excreting properly. Now, Lasix acts on which organ? Kidneys. And wait, kidneys aren't working properly. That's why we have hyperkalemia. So it's usually not preferred. Kxalate is preferred because it acts through the GI tract. Okay. Perfect. So you got to see how we worked. Step one, I see hyperkalemia. I get me my EKG. My EKG is showing me hyperkalemia. This is unstable. This is unstable, and this is for real. Okay, this is unstable, and this is for real. Sorry about that. Stable and real. My number one priority, protect the heart. I gotta buy minutes with calcium chloride, hours by redistributing potassium inside the cell with three methods: insulin plus D50 and or sodium bicarbonate and or albuterol. If there's indications for dialysis, let's do it. Okay. What if the EKG does not show hyperkalemia? Well, then that tells you two things. Either there is no hyperkalemia, or if there is hyperkalemia, it's stable. Those are the two possibilities, right? Okay, so the first thing I got to do is recheck the potassium. So you're going to see your provider once they review the EKG, or once you notify them what EKG is showing, and tell them and share with them that it's not hyperkalemia that is showing up on EKG. There might be an order to recheck the potassium. And this time they might say, hey, when you're drawing the blood, do it without the tourniquet. Why is that? Well, the tourniquet applies pressure and squeezes on the blood vessel, which squeezes on the red blood cells that actually lyse or break down. And when they lyse, they release all that potassium inside the cell to outside the cell, causing a false elevation in the plasma uh, potassium levels, which are levels outside the cell. So this time they're going to say, don't put the tourniquet on. That way the cells are not going to be hemolyzed. Okay. Now you draw it, and turns out you get normal potassium. Well, guess what? There was no hyperkalemia. You got saved. There may be another option, which is that you do see a hyperkalemia. That means the hyperkalemia is for real, but it's stable. When things are stable, it's not emergent. Then we have some time, and we need to excrete the total body potassium. And we have days. And guess how we do it? It's exactly the same two ways, which is Kxalate and or Lasix. And Kxalate is usually the drug of choice because a lot of times we run into issues with kidneys, which are causing the hyperkalemia in the first place. And Lasix, our second option, depends on kidneys working well. With me on this? Easy, right? Okay. Let's see Kxalate and how it works. So again, you give somebody Kxalate, it goes in your stomach. It releases sodium and calcium ions that are my cations and takes up the hydrogen ion. It then goes into my large intestine where it gives up the hydrogen ions and takes up the potassium and then gets eliminated in the feces. So essentially, the oxalate's big work is done in the large intestine where it gives the hydrogen ion and takes up the potassium. And then we excrete that extra potassium in the feces, so it binds. So it's a resin that binds the potassium and takes it out. So that's what it does. We can give it by mouth, in which case it goes through the large intestines and the GI tract and pulls out more potassium, but it takes longer. Or we can give it by rectum, where it acts more immediately, but it doesn't pull as much potassium. Because remember, now it's got a very narrow window of time where it's working in a narrow anatomical area where it's working. Okay? The providers may choose to do both PO and PR at the same time, which means it starts to work faster, and then I've already introduced stuff in through the by mouth where it can be more effective. Okay? Side effects, electrolyte disorder, all these electrolytes moving in and out. Keep an eye on the potassium. And again, because it works on the intestinal level, there's intestinal injury and a chance for that. Okay? You guys see this? Whenever you see a patient scenario with hyperkalemia, follow this protocol and you will have the right answer. Clinically, hand on the tests. Okay? Now, we've still got to cover hypokalemia. Okay? This, my friends, is hypokalemia, which is potassium less than 3.5. What do? We do an EKG again. Again, we call the provider. Provider might order an EKG. Hey, is the EKG showing flattened T waves? Is it showing a U wave? Yes. Now you have something that's unstable and real. You have unstable, real hypokalemia. I got to replace it. And when I do it replacement, I'm going to do IV replacement because it's unstable. I'm going to give it, if I give it by PIV, I can't go over 10 milliequivalents an hour. If I have a peripheral IV, if I have a central line, I can't go over 20 milliequivalents an hour. And I replace. And I watch out for fluid imbalances because I'm giving them fluid. If the solution has tonicity issues, I watch out for that. If I'm giving sodiums, I got to check for that. And then as I'm giving potassium, I got to check their EKG and make sure they don't have any signs of heart issues that are jumping up. And remember, what else? Keep that eye on that magnesium, man. You see that potassium down, check the magnesium, because they actually might need magnesium replacement as well. Okay, good. So now you see your EKG and it shows us hypokalemia. It's unstable and real, and you treat it. Well, what if it doesn't show any hypokalemia? There's two possibilities. Again, you might have what? A normal patient with no hypokalemia. Or you might have a patient with hypokalemia, but it's stable. So what do? We recheck the potassium levels. And if the potassium levels are normal, we got a normal patient, we got an error. We do not replace. If on rechecking it shows hypokalemia, then it's stable and real, right? Then we replace it by mouth. Maybe a little potassium chloride, 40 milliequivalents. We dose it by mouth and we check and we see if that fixed it. Okay? And that's the simple algorithm and decision tree for a patient and how you approach them if they are hypokalemic on tests and in real life. Okay? If I were to say, In which order do you do the tests? You can tell me. I do the EKG first, then I check their levels depending on what's going on with the EKG. And again, if the EKG actually shows stuff, I know exactly what I need to do and what the provider will order, and I'm going to get that stuff ready. Okay. Interventions. Intervene. Biggest thing. K, EKG. Watch out for the electrical abnormalities and arrhythmias. If you are removing K, be careful. If you're replacing, be careful. If you're replacing, do it slowly. If they're having low potassium, check their levels, magnesium levels. If you're removing K, if you're removing potassium, be careful because they are hyperkalemic, which means they might run into some of the complications of high potassium, which may be cardiac arrhythmias. Okay, everybody got it? See, that's how easy that is. So let's go over what we studied, what we went over this lecture real quick. Okay. So again, what did we go over? We went over potassium, where it's more, intracellular space, where it's less, extracellular space. We went over how narrow it is. What's the big issue? Arrhythmias, EKG and K. We went over the most specific symptom, what you're going to see on the test and what you're going to see in real life when you're teasing this out, and how T waves, peak T waves give you hyperkalemia, flattened T waves give you hypokalemia. U wave, hypokalemia, prolonged QRS, flattening and moving away from QRS gives you hyperkalemia. That's what you suspect. Usually you'd have a patient with some kind of renal failure, patient on dialysis. Okay, these are some patients that would come in the questions on tests, and suddenly they're having nausea and vomiting. Has non-specific, right? And the provider orders an EKG, and we suddenly have peak T waves. So the test maker is testing whether you put renal failure and symptoms of hyperkalemia in the same room, and can this person recognize what's going on? This is unstable real hyperkalemia. It's an emergency. Something needs to be done or they're going to go into VFib and BTAC and they're going to die very quickly. Okay? We talked about how high potassium and low potassium get generated from kidneys, renal causes, or low intake or high intake, or redistribution in and out of extracellular and intracellular spaces. Okay, check how to measure potassium in solutions, how to replace potassium. Okay, not giving it bolus. When we're giving potassium through IV through a central line, we do it less than 20 milliequivalents an hour. When it's through PIV, it's less than 10 milliequivalents per hour. And when you see hypokalemia, check their magnesium. That needs to be replaced as well if that's low. Okay. We then looked at what the goal of the treatment is. And then we then looked at if we've got to diagnose it a bit more, how we can use urine sodium to shore up renal and non-renal causes of hyper and hypokalemia. But the money is actually in management of hyper and hypokalemia, and we went through how our first stop is to get EKG in both, which would tell us whether the lab value is real and unstable, or if the EKG is normal, it's either we don't have the issue and the first value was spurious or false, or the first value was real but it's stable. That's why the EKG is not showing up symptoms. If hyperkalemia, it's real and unstable with a bad EKG, calcium chloride to stabilize for minutes, redistributing it inside the cells which would give us ours with insulin plus D50 and or sodium bicarbonate and or albuterol or beta-2 agonist and or consider acute dialysis, and get rid of total body potassium while you have those Rs with Kxalate, which is preferred. If we recheck and the value is normal, then there was no hyperkalemia. But if there is hyperkalemia on rechecking, then it's stable and real. Then we have time. We just need to excrete total body potassium using Kxalate. We went over how that works. The last part of this that we went over was if you have hypokalemia. We do an EKG. If it shows hypokalemia, it's unstable and real. Gotta replace IV and gotta be careful of the rates. We gotta give potassium through IV. Patient safety. Okay. And if the EKG is good, then we recheck the levels again to see if the potassium is normal. If it is, don't worry about it. You don't need to replace it. The first value was false. However, if on rechecking it shows hyperkalemia, it's real, but it's stable. So you can replace it by mouth if possible. And again, nursing intervention. Very careful observation for cardiac arrhythmias. If you're replacing, do it slowly. Don't be bolusing these patients with potassium, or you're going to execute the patient.